I'm currently an MSK specialist physiotherapist working for the IMPReS team, which is Integrated MSK Pain and Rheumatology Service at East Lancashire Hospital, NHS Trust. The internship that I was on was the NIHR ARC internship, which was 1 year duration. The theme is improving population health and patient-centred complex care theme. The title of the research project is The Barriers and Facilitators to Exercise Engagement in People Over 60 at Risk of Falls. Started 2 years ago, 3 years ago now, looking into this area, and I've just received ethical approval from the Health Research Authority, and going through this stage of finalising the trust sponsorship. I will be interviewing patients who have already been diagnosed with a risk of falls by physio clinicians here in MSK. And then they've been given exercises to complete at home, which is to help reduce their risk of falls, improve their balance and strength. So I'll be interviewing using semi-structured interviews and hoping to find out their thoughts on exercise engagement, looking at they prefer things like leaflets, website, online, tech services, and their compliance and understanding. So looking at the communication with health professionals that they've had their care from and their thoughts around the risk of falls or improvement of our services further. At the moment, fragility and falls is the national priority. So the World Health Organization have wanted to focus on this. At the moment, we have the NICE guidelines from 2013, which say that every health professional should be screening for those patients at risk of falls. And obviously the guidelines are updated next year, so it's up and coming. We'll hopefully get a lot more from that. We know locally we have over the above level of hip fractures and A&E attendances because of those who have fallen. And so it's important that we look at managing that from patient health, but also from costing. Have cost of 2.3 billion on the NHS from falls. Obviously those long-term conditions and the impact that has on their mobility, that's more up to 7 billion. So there is a big cost and a big demand on sustainability of health services from people that are falling and injuring themselves. I mean, in current practice, so the current research, there's a gap there because in the Northwest, there is a lack of research looking at exercise compliance. And we know that balance and strength exercises reduce the risk of falling by 25%. That goes up to about 35% with resistance exercises. It's not the only thing that helps reduce the risk of falls. We know there's other components, but as physios in our service, we do give out exercises regularly for patients who come in. And so it's looking at identifying those who would benefit from a balance or a strength exercise if they've had an upper condition, so a fracture or a muscle tear or something like that, as well as looking at the lower limb. So it's looking at as a service, can we help just to improve that awareness of falling and the pathway that patients can go down to prevent them, to take some awareness themselves of how to prevent falls, but also to help reduce the risk of them and get people exercising a little bit more, I guess, the promotion of that. So there's quite a lot there that it does cover, but the basis of the research is just trying to find out patient opinions as the first stage to help inform where we go next. I have a PPI engagement group. They have helped identify the falls and exercises as a topic that they feel strongly about on an informal basis. We have patients coming through to us regularly, and they've also disclosed in class environments on a one-to-one about exercises that we give or about their risk of falls. So we know the topic is there to explore. My PPI team have also reviewed all my protocol, my patient-facing documents, consent form, the interview schedule, and contributed to that. They've also helped have practice mock interviews, so they can comment on the style of questioning and any sort of, how best to go to roll out the questionnaires and interviews. They will also contribute to, once I've got the results, So then looking at what we do and how we disseminate that, and you know, how we can help reduce health inequalities through the project findings. Health inequalities, I work for ELHT, and we have lots of different areas to our patch. There's a large variety of different patients, different service users who may have a difference in education, language barrier, status, literacy, age, and so it covers a wide variety of patients who all have different needs. And that's important that we do research in the Northwest to help manage and improve their access to care. In terms of my specific research, we're looking at age. So looking at if there is any ageist sort of thoughts or beliefs. We're looking at the use of leaflets. Do they need them bigger? Do they need to have things given as leaflets, or do they prefer the online apps, texting? You know, do patients want that to help improve their compliance with exercise programs? So it's all there to help improve the quality of care that we provide for them. And their quality of life. That's one way of doing it. And also in the area, we have different things available, so different levels of funding. So we've got high rates of falls and hip fractures across our patch, but some areas that have a slightly higher prevalence of this might have more funding for falls and groups and falls services, and community access to like exercise classes and other areas. So there's a bit of an imbalance there, because all populations do have that risk of falling as well. So it's looking at that, and then obviously non-English speakers, and we need to look at how we manage that sort of population a little bit better with the information we give as physio clinicians as well. We've got a template that I've created about a year or so ago that has picked up, those patients who are at risk of falls, but also identifies any of those patients from there who are interested in consenting to the research. So from there, I'm going to take a sample and I'm going to contact them, see if they want to be involved in the research, go through it a little bit more with them, and send out the PIS and the consent form to them by email or post. And then weeks later, I'm going to get them to contact them again if they're interested. Then we can go through interview either via Teams, on site here, depending on their preference. So all going, sticking to the protocol. It's all been sort of written out through there, addressing safeguard and confidentiality. So and then after that, I'm going to hopefully interview up to about 10. So starting off with a small one, because it's my first research project. Looking at transcribing and seeing if there's any common themes and analysing that using NViva, and then hopefully writing it out thereafter. Firstly, the patients themselves and service users will benefit from the research. So we're looking at, in the short term, trying to get patients complying and doing their exercise programs they've been given. So it may well be, say, for example, the research may show that we need to either remind patients to do it, or how it's made more of a priority, make it easier for them to access or to read. So anything that they come up with will help improve how we deliver our services, to communicate it a bit better, go through more of a shared decision-making process together. So that's sort of the patient side of it. And the idea is if they can complete exercises better, then they might help improve their balance and prevent falling, prevent other injuries and attendances to A&E and returning back into the service. So it'll improve patients and their quality of life from that aspect, and obviously physical as well as mental health of these patients. It will also then help with the wider population if we can then disseminate that out across the patch. From a staffing point of view, it will help us develop more pathways. So we are currently looking at the falls and fragility pathways here in MSK and ELHT. I'm looking at identifying better these patients who are at risk of falls and what sort of level and what is appropriate rehab or appropriate referral for them, and signposting better. So that will help from management of patients, but also from staffing, training better and identifying these patients better, moving them on at the right time to the right place. Overall, from a service point of view, we're looking at that, obviously, patient safety, the quality of care, but also the costing. So trying to cut down on service users accessing A&E because they've had a fall or hip fracture, trying to look at, instead of we're responding to patients who have come through to physio with injuries and dealing with the injury that they're in with, we're trying to look at how we can better prevent them from falling or fracturing in the future as well. Completing the internship was in March this year, and then I was lucky to get onto an NIHR PRN Greater Manchester scholarship. So I'm on a research scholarship now for 2 years. I'm still with NIHR, just a different branch of it. And that's been really good because now I get a day a week allocated to research, which means that I can firstly develop this project and continue with it. Also, it allows me to experience networking with other research professionals and get some more training in research, such as leadership, project management, team building. So all this is really good to help me develop as a researcher, but also as a clinician. And in MSK Physio, we work towards the 4 pillars. Research has also not enabled me to be better at research. It also helps from a clinical point of view, because I'm now trying to get more research and evidence-based practice into our everyday delivery of different conditions. So I'm also part of a spinal SIG or spinal interest. So, for example, it helps us listen to the podcast and up-to-date research on how to manage certain conditions, so like lateral spinal stenosis is one example, and then looking at how we kind of service influence the pathway of that and how we then improve our patient care. So it helps improve and inform all aspects of our clinical delivery. And it also education is the other pillar. So that means that I educate, I've got more confidence in myself and a lot of presentations and delivery of things. And so education and training with both my local team with this pilot that we're running here at Rosendale, but also from a staff point of view, a team point of view, and then wider with all my teams that are involved in my research. So gaining a little bit more leadership skills as well, which is the 3rd pillar, because I'm having to sort of navigate the landscape a little bit, the research landscape, and try and sort of link up that education and health service as well as research. So trying to do that, promoting research as well. Research is our 4th pillar. So looking at trying to get more AHPs and MSK clinicians more involved in research and embedding it more in our daily practice, because we know that it helps improve both staff retention and morale at work, but also obviously patient and evidence-based care. So I think that this has totally improved my confidence in all those aspects, and it's made me realise how much I do love research and then the academic side of it, and carrying out something that actually will influence patients and their improvement and in their long-term conditions, and looking at that wider picture, really. So it's been amazing.